Morning, everyone. Welcome to the APO AIS joint meeting, and we will be starting this very interesting session on glaucoma surgery, advancements and innovation with some of the top speakers from the Asia Pacific region, USA and Europe. And I like to invite our first speaker, Dr. Ying Han, who will be giving a talk on first-line surgical options for primary open-angle glaucoma and primary angle closure glaucoma.
Good morning. Thank you so much for the invitation. It's really my pleasure to be here today and share this topic with you. I think it's just give the whole picture for this session, and there's the speakers who follow me will give the detailed information about each glaucoma surgery. I don't have financial disclosure, but there's a grant funding I want to thank for. First, I want to talk about open-angle glaucoma. What's the first-line treatment in my mind? I think it's dependent on patient's condition. I group them with the younger patient, older patients. If it truly is a younger patient, to me, like the open the trabecular meshwork either by GAT or Omni or suture trabeculotomy works really well. This counts for juvenile glaucoma, steroid-induced glaucoma, or uveitis glaucoma when there's no active inflammations. When people are getting older, when they have open angle, and then if you want to do the surgery, really thinking the first line is how much the pressure you want to control. This is dependent on the patient's situation. To me, I don't think the severity of a glaucoma counts too much. Let's say if your goal is just to lower some degree of pressure by 1 or 2 millimercury, or if you want to decrease the medication load, then you can thinking about the minimally invasive glaucoma surgery, even for patient has advanced glaucoma in my mind. For example, the iStent Infinity we're using here. Now we're using the 3 iStent now. Works really well in my hand as for both open and narrow angle patient. After cataract surgery, we got the pressure almost like a single digit or low teens when they postdoc, and with long run, so mid-teens. And also you can do a stand-alone procedure. Hydrus is another broadly used in the US mixed surgery, and this is only a mix, as far as I know, shows we can preserve a visual field at 5 years after the place the Hydrus. Besides that, there's also goniotomy, use KDB or Omni or other instrument. Also cyclophotocoagulation, such as a micropulse or ECP. So for the micropulse, has been a paper reported that show you could choose it as a first-line primary treatment for the open-angle glaucoma patient, but I feel like you need to be very careful about this selection because I do have complications with the micropulse, such as irregular pupil, hypony, and also some cornea epithelial defect persisted due to the neurotrophic changes. And later on, we're going to hear some newer mix, such as placing in the supraciliary space. For the patients who need a better pressure control in the long term, such as like a low teens or single digit, really for those kind of patients, there's a different type of surgery you can choose, such like a Zen gel stent. What we are doing here in the U.S. is we normally do like external placement, and also I like to choose the patients like older Caucasian, has less scar tissue formation, and also we use lots of bleb needling at early stage. Preserved flow is not available in the U.S., but has been broadly used in other countries. The reason for that is there is a RCT randomized clinical trial compared the microshunt preserved flow versus trabeculectomy, and it shows actually trabeculectomy has a better pressure control compared to the preserved flow. But even that, we can get a relatively low teens pressure with preserved flow and with less complications. Otherwise, we're also familiar deep sclerotomy, trabeculectomy, or tube shunt surgery. Those are all incisional surgery. Deep sclerotomy, broadly used in some countries, really want to decrease the cost of the patients. For the tube shunt surgery, there's a newer type of tubes, such as a PAL implant, has been broadly used Asian and Europe. The most advantage of PAL implant is it has like a smaller diameter of the tube lumen. We're hoping like this will minimize the complications postoperatively and also minimize the cornea damage. So there's tube locations. As we all know, like you can put an AC tube, you can put a sulcus tube, and if needed, and you can put the tube in the pars plana to best protect the cornea. So the left side is a surgery video to show to put the sulcus tube. We normally is a dilated patient. And also the key here is bevel down, and we really need to see the tip of the tube by the end of the surgery. And on the right side is a video to show the pars plana tube. For this kind of a tube, it's, sometimes the patient has no space in anterior chamber or sulcus. So really at this situation, you have to thinking about where to do that. So for this patient, we have to remove the pupillary membrane and afterwards and create a space. But even that, because there's not enough space, we end up put the tube into the pars plana. So that's require vitrectomy. So one thing actually I learned with sulcus and the pars plana tube is I really don't have a shallow chamber anymore when we put the tube to the back. The reason for that is because we really drain the fluid from back and maintain the balance of pressure front of eye and the back of the eye. So we got really good balance and we don't have a shallow chamber. If you put the tube in the anterior chamber, then you causing the imbalanced pressure of the front of eye and the back of eye, that has the possibility of causing the shallow chamber. So we really want to put the tube away from the cornea. There's many studies to show that, including ourselves. However, people are arguing that you could put a tube into the sulcus, but really tenting up the iris, would that causing cornea damage? Or on the other hand, if I put the tube in AC, but they're really, really well parallel to the iris, that will minimize the cornea damage. So really for this question, we don't have a good answer. So that's why we're conducting currently a trial called a glaucoma drainage device and endothelial cell loss compared trial, the DECLARE trial, to better understand the damage of a cornea endothelial cell after the tube shunt surgery. And I want to show you a few examples. Those are spectral macroscopy for patients that has a clear cornea before the tube shunt surgery. So this is before the surgery, and you can already see the cornea endothelium is not great. And this is their endothelial cell count. And look at the solid line. That's the manual grading of endothelial cell. About 25% of patients before the surgery, before the tube shunt surgery, they have endothelial cell less than 1,500. And this is further confirmed with our more patients enrolled. About the 25 percentile of endothelial cell count is 1,500. And now we're having over 100 patients enrolled, so we're really looking forward for the report. For the more complex patient, then what we have to do is the tube probably will be the easier, better outcome as a first-line treatment. When for the complex patient, this is a patient after TRAB multiple times at this point. So we're thinking about, there's when we try to close the conjunctiva, but there's a space, we have a really hard time to close the conjunctiva. The key here is not to pull the conjunctiva too much, so we end up just put a vision graft, which is a transparent cornea tissue, right over the tube, the exposure area, and cover with amniotic membrane. That works really well for those complex cases. So those are for the open-angle first-line treatment. For the angle closure glaucoma, the first-line treatment, really the cataract surgery plays a significant role. It started from EAGLE study told us, we can even do clear lens extraction for the patients, and they have a great outcome. So that's what we're doing for the clear lens for the narrow-angle patient. And also, Professor Zhang from China has clear study showed that if you combine the lens cataract surgery with synechilysis and goniotomy, you really get a well-controlled pressure for even for the advanced primary angle closure patient. So this is a save them from really the trabeculectomy, which has a much higher risk. She has a RCT published in JAMA Ophthalmology this month. So in summary, we want to choose the type of surgery based on patient's needs. The new types of glaucoma surgery is coming, and we want to develop the surgical technique working best for us, and we want to optimize in pre and post-op conditions. Thank you so much. This is my collaboration.
Thank you, Dr. Ying. So just one question for you. You mentioned micropulse laser as a first-line therapy. What about using SLT as a first-line therapy for primary open-angle glaucoma before any of the MIGS options?
SLT, I think my topic here is a surgical option, so that's why I did not mention SLT. So I think because of light study, we are using SLT even before medical treatment to treat the primary open-angle glaucoma or ocular hypertension. The study shows really good outcome. So when I present to the patient, I say, based on this result, like a trial result, I think a laser will work for you, and we do SLT even earlier than the medication. The micropulse, we normally do it, at least you have to do retrobarbal block, right? Or general anesthesia, because it's a painful procedure much more than SLT.
And do you have any preference for using a stent versus using a cutting procedure? Any preference?
The stent, so we're talking about the Hydrus iStent or Zen PreserveFlow.
Just the trabecular stent versus trabecular cutting.
Okay, yes, very good question. I don't think that there is a clear comparison between trabecular stent versus a goniotomy. I think it's really depend on the patient situation. For younger patient, I think a goniotomy works really better than we just put a stent there. Older patients, maybe there is, we're lacking of a study to show which one is better than the other one. I think we also need to thinking about the long term, because if you cut the tissue versus you put the hardware into the TM, which one's better? In most of the situation, they don't lower pressure that much, just lower by a few millimercury. So it's also you need to meet the expectation of your goal of the surgery.
Thank you so much.
Thanks so much.
Can we have the audiovisual to put up the talk by Dr. Ziolan? She's not here because of some visa issues. So do you have a pre-recorded talk? Yeah, can you please start that?
Guangzhou, China. I would like to present incorporating mix for PACG. I don't have financial disclosure. More and more studies show that mix can be applied for PACG by through phaco plus GSL. For example, even though off-label, phaco plus iStent is effective for PACG. Phaco plus trabectine can achieve a good IOP reduction too. Even though it is a case report, phaco plus Hydrus show he can successfully reduce the IOP. Even though contraindication, phaco plus Zen is effective for PACG. However, going through all kinds of surgery, phaco goniotomy is the most cost-effective procedure. Phaco goniotomy can work well for advanced PACG with cataract because phaco can solve shallow anterior chamber, GSL can solve PAS, and GT can solve dysfunctional trabecular meshwork. Our team already published half-year, 1 year, 2 year, and 3 year surgical outcome. Great IOP reduction, high complete and qualified success rate. Multi-center non-inferiority RCT to compare phaco goniotomy versus phaco trabeculectomy in advanced PACG with cataract. 1 year result have been published in APJO, and the 2 year result is in press in drama ophthalmology. Both results show that phaco goniotomy is non-inferior to phaco trabeculectomy. And phaco goniotomy has less complication, less time-consuming, less cost, and more improvement in quality of life. For clear lens, phaco goniotomy can be performed in cases with extremely shallow anterior chamber, a thick lens with a high valve, and any high risk of malignant glaucoma following trabeculectomy. For advanced PACG without cataract, another new combination surgery that is SPI plus GSL plus GT can work well too. Half-year, 1 year, 2 year surgical outcome show that this new combination surgery has a great IOP reduction and good quantified success rate. And the 1 year RCT to compare trabeculectomy showed out SPI plus GSL plus GT was not inferior to trabeculectomy. Moreover, goniotomy with or without phaco or GSL can save some cases who failed in previous surgery. So based on above studies, we believe that the new combination surgery can bring new option or new innovation in PACG. SPI plus GSL plus GT will replace trabeculectomy, and the phaco goniotomy or another mix will replace phaco trabeculectomy. And we hope one day in the future they can adopt into consensus or guideline. Thank you all the wonderful experts support and guide us. And thank you all the members of our multi-center study group. Let me summary. Growing evidence showed that mix can be used in PACG. Mix for PACG can be applied by through phaco plus GSL. And phaco plus GSL plus mix has effective in PACG. And phaco goniotomy show promising future for PACG. Future chance for PACG is revolutionizing trabeculectomy, and phaco trabeculectomy would be praised. I will show you 2 videos. Thank you, organizer, invited me here. My name is Julan Zhang, came from Center.
Thank you. We move on to the next presentation, and that is supraciliary stents, and that was to be done by Dr. Kaveh Mansoori. Unfortunately, there's a flight issue, so he'll be arriving late. So Dr. Nitika Berry, Assistant Professor, University College of Medical Sciences, has kindly agreed on a short notice to present his slides. So I would request the audience not to ask any questions to her. Thank you.
Thank you very much. A very good morning to all of you. Respected seniors and dear friends, I'll be presenting on behalf of Professor Mansoori today, and the topic of my presentation is supraciliary stents are the future of minimally invasive glaucoma surgeries. My name is Dr. Nitika Berry, and I'm working as an assistant professor at University College of Medical Sciences. These are the financial disclosures for SIR. So let's start by looking at the challenges what traditional glaucoma surgeries face. 1. Creation of blebs results in risk of delayed infections due to bleb leaks. 2. Post-op challenges of inflammation and fibrosis, which requires the need for chronic anti-inflammatory agents. 3. There is delay in the visual recovery post these surgeries. 4. There's an increased risk of ocular surface diseases. And 5. There are multiple intra- and post-operative surgeon-dependent variables affecting the outcomes of this surgery. So what do we need now? We need better glaucoma surgeries, which can be ab internal, can give us the safer IOP reduction, can be minimally traumatic, and provide us with rapid visual recovery. So we all are familiar with minimally invasive glaucoma surgeries, and we have angle-based procedures, bleb-based procedures for minimally invasive, and the concept of minimally invasive glaucoma surgeries targeting the supraciliary space. I would like to show that this concept of creating a cyclodialysis cleft is as old as 1905, given by Dr. Leopold Henle, who targeted this space and showed that that could be a route for decreasing the intraocular pressure. And now, with the new era and the devices, we can target this space, and we have Miniject, that is made of proprietary star material. It is soft, flexible, with antifibrotic properties, and micropores enable a natural flow of speed of the fluid. We can see here that the green ring over here acts as a surgical marker for the placement, and that should be visible at the scleral spur. The surgical procedures with which we can combine this is either a standalone procedure, and we can even combine it with our phaco surgeries. It's an ab interno approach and requires a corneal incision of less than 2.2 mm. So this is a surgical video to please show the insertion of Miniject. Just like any other minimally invasive glaucoma surgery, we do a direct gonioscopy and visualize the angle. And the device is then inserted. Moving forward, so Miniject allows for a direct communication between the anterior chamber and the supraciliary space, as we can see in this photograph. So it's a creation of a controlled cyclodialysis cleft, and the access is similar to the angle-based surgeries, just like we saw in the video, and has the big advantage that it is bleb-free. So the traditional challenges that we are facing with the bleb can be overcome with this technique. So let's look together what the literature has to say. So the recently published meta-analysis with the STAR 123 trials pooled data from 11 sites, which had the objective of assessing the efficacy and safety of Miniject in a standalone procedure in patients of primary open-angle glaucoma uncontrolled by medication, which was published in American Journal of Ophthalmology recently. And they included mostly patients of mild to moderate glaucoma with a mean IOP of 23.8 millimeters of mercury and the mean number of ocular hypertensive medication to be around 2.4. They found that at 2 years, with a success criteria of IOP being achieved to less than or equal to 21 millimeters of mercury, with more than 20% of IOP reduction from baseline with or without glaucoma medication, the success rate was 89%, and there were 38% patients who were medication-free. So the common adverse event noted was anterior chamber inflammation in this data. Looking at the 3-year results at the STAR Global Extension Trial, they found that the patients with more than or equal to 20% IOP reduction for baseline was noted in about 90% of the patient, and 45% of the patients went medication-free. This is a graphical representation of the data, which we just saw. So let's look at the adverse events which we all would like to know. So the mean central endothelial cell loss at 3 years was noted to be about 4.7%, and within the study, only one patient had more than 30% loss. Secondary surgical interventions were needed in about 6.3% of the patients. So moving further on the long-term data, the STAR1 data showed at 5 years that patients with more than 20% of IOP reduction from baseline was noted to be in 83% of the patients, which is encouraging, and the medication-free patients were almost 40%. This is, again, the graphical representation. And now the safety data, which we all would like to know. So the mean central loss of endothelial cell density from baseline was noted to be about 16.1%. So Mini-Ject is not the only suprachoroidal MIGS. We also have a biostent. So this is a biostent tissue. As we can see, it's a scleral allograft tissue which is inserted during a cataract surgery. So we create a cyclodialysis cleft, and through an injector, this allograft is inserted, as you can see in the photograph here. This scleral allograft, which helps keep that cyclodialysis cleft patent. In a recent study by Atlantic Allopass, 10 eyes with open-angle glaucoma combined phaco-biostent surgery with a 1-year follow-up. The endothelial cell loss was seen to be about 11% at 1 year, and there were encouraging results in terms of IOP reduction and medication reductions as well. So I would like to conclude that the supraciliary and suprachoroidal space can again be accessed in a minimally invasive way, just like it was thought in 1905. Mini-Ject drainage device seems to be safe with the 5-year data that we now have, and highly efficacious. There is no indication so far of the CyPass level of endothelial cell loss that was seen. About more than 2,000 implantations across Europe for Mini-Ject has been seen, and there are other approaches emerging as well. And now we have the long-term data which is available with this device. I would like to invite you all to the 11th World Glaucoma Congress to be held at Honolulu, Hawaii from June 25th to 28th. Looking forward to seeing you all there. Thank you very much for your patient listening.
Thank you, Nitika. Very nicely presented. So we don't have any experience in India with supraciliary implant. So maybe Dr. Keith Barton or Shan Lin, could you share your experience about the suprachoroidal implant or the Mini-Ject? Would they be replacing traditional MIGS surgeries, trabecular MIGS?
Shan's probably better positioned to speak than me because he's actually the medical monitor of the FDA trial. I mean, I've done a few, but I've not done a huge number. You know, suprachoroidal devices, as I still keep calling them, the suprachoroidal space has better potential than anywhere else, but it's been proving so far impossible to harness predictably. And all of these devices have a proportion of patients that will go too low and a proportion of patients where they'll fail and the pressure will go through the roof. And it's just tweaking it so we can alter these proportions that's the challenge. I think you should ask Shan to say a few words, because he's a lot more, a much better perspective than I have.
That's very kind of Keith. Keith is one of our principal investigators for the Mini-Ject, so he speaks from experience, and I've done it as well in a foreign country, so I can speak from experience of doing it. Keith is correct. You know, I get to see, you know, the good, the bad, and the ugly, and so I would say that overall it works very well. You know, the ones that I see as the medical monitor, of course, are the ones that may have some issues going on, but that's a minority of them. I think technique is a critical aspect. I think you'll probably agree that your risk for having the tube a little too anterior, like we had with side pass and causing endothelial loss, so much involved in the learning curve of doing it. But if it's done right, actually the vast majority of people have good pressures, reduction of medications, and the risk of hypotony also probably is related to, just it's a fine balance between creating that cleft and creating too big a cleft. So, again, technique and luck comes into it a little bit too.
I've got to say another word. I think Alex wants a word as well. My experiences with the mini-ject is that the post-operative care seems to be less dramatic than it was with CyPass. I know the iStent Supra never made it to market, but my knowledge that, on the grapevine about the iStent Supra was that there were some fairly dramatic pressure rises when it failed. The CyPass had perforations in it that the iStent Supra didn't, so it had more exit points. So maybe that's why it's anecdotally it was a little less likely to do that. And the mini-ject, even though it's a bigger thing, is a softer, spongier, and seems to be a bit less dramatic as well. So maybe we are slowly getting there. I'm not sure. Alex?
Alex Wong, UC San Diego. I consulted with a number of companies, but nothing to do with this. And I haven't done any mini-jects myself, but we've been starting to do allophones. And I'll be speaking about this on Saturday as well at the AIOS meeting. I mean, there are some mysteries here, right? The fact is, why isn't this way more powerful? And, as Keith was saying, in terms of that untapped potential, and also on the other hand, more dangerous, because we don't really see bad things. I mean, with the allophobe, you actually make your own cleft. You put in pieces, you even leave a huge hole, and you think you'd be facing hypotony all the time, but you don't really see it in their data in my hands as well. And so this is, I believe, the next frontier, and there has to be something that's not fully understood yet, because it should be stronger, it should be scarier, maybe for some of the more advanced cases, and it's really been neither. It's kind of behaving like regular trabecular MIGS with the pressure spikes that Keith mentioned, particularly with CyPass.
May I ask, just there's a few sort of things about it that obviously history has taught us a little bit, but do you think materials actually matter in this space? I mean, we don't get to observe it, we don't really get to dissect blebs, we don't have a sense of.
So I think material does matter. The best evidence for that is going to be the Solix gold shine. So that material seemed to, at least when I pulled it out, had a ton of fibrosis around it, right? I don't know about CyPass, the other ones, and in the case of allophobe, it's just sclera. But I think the choice may matter.
Just put on the mic.
I think the material matters because just for the CyPass case, you really has a hard time to pull the CyPass out. And also paper published to show there's a scar tissue formed posterior to the CyPass, which is related to the IOP control. So even in the suprachoroidal space, you think there's no scar tissue form, but actually there is happening.
Yeah, the common wisdom is that there are two issues going on in subconjunctival blebs. One is the process attached to the implant itself, so foreign body scarring, and the other is the hydraulic stress. What we don't really know about in the suprachoroidal space is the hydraulic stress response. No one's ever looked at that, and we don't understand what it is. You'd expect it to be less because it's much more intraocular pressure. So the one thing that if you talk about CyPass or its children is whether or not the hydraulic stress will end up being a continued problem, which means the material probably is more important. Does that make sense?
Yeah, I mean, the fibroblast reaction, I mean, if you look at the pressure flow, they made a big deal out of it being a very inert material, but in the end up, that's kind of icing on the cake, because the problem is that aqueous causes scarring. So your material can be as inert as you like, but you'll still get scarring unless you have aqueous that doesn't cause scarring. And it's got and if you revise a pressure flow and go in, it can be like cartilage around the external. It can be fairly dramatic, but everybody knows this. This is not new, as you said. We know that the suprachoroidal space scars like crazy. It's a question, I suppose, as you said, hydraulic pressure, but flow. I mean, there's always been this thing with tubes, for instance. The proponents of things like the Amid valve like the early flow because it gives you some moderate pressure control, whereas the non-valved, a lot of the non-valved implants, people said early flow is bad, it
Yeah.
creates scarring with the aqueous. But in fact, we've been doing for years with bar valves with a little bit of early flow, and a little bit of early flow doesn't predispose to failure, I don't think. So then the question is, if you've got a side pass, which is a big pipe going in, you're getting a lot of aqueous going in quickly. If you've got a mini jet, which is kind of a spongy thing that probably is moderating the flow and going in more slowly, maybe that has a similar effect. So you're not getting it.
I suspect my co-chair is going to make us move on.
Yeah. There's a lot of
So one final comment, Dr. JC Das,
There may
please.
be some benefits there.
Yeah.
We just don't know. This
I
is
think-
all hypothetical.
I think the flow diagram or the flow equation is very different because it's intraocular. So I don't actually know what is happening in the suprachoroidal space. I mean,
Well,
I think
it's
it's
scarring, we know that.
yeah. I don't know whether it's quite as hydraulic.
So
though.
we'll have to move on. Thank you, Keith and Shan. Dr. JC Das, one last comment, please.
And what about the gold implants? Because 15 years back, it was quite popular in Germany. The two layered gold plates
Yeah,
with the
yeah,
perforations
Solex,
and
yeah.
works very well. And
Yeah.
it started 15 years, 20 years back in Germany and was quite popular.
Yeah.
And I'm not seeing it in anywhere now. What
it's-
about that? Any experience of our?
It was withdrawn quite a while back. Yeah. It had multiple possible channels, and you could hit it with a laser.
Yeah. And it draws the fluid by hypotonic action, and it was quite effective. I've seen
I
few
think-
cases.
Yeah.
It is working well.
I think they're
no
all
improvement,
effective.
no further improvement on that.
They're all effective for a while. It's the predictability and the safety problem, isn't it? The advantage, which is I'm getting a kick along. The advantage of subconjunctival drainage with all its disadvantages, at least you can see what's going on. I need to introduce our next speaker, Amit Powell, who is actually from Indra here and is one of the organising for the All India Ophthalmic Society. I think that's correct. Lovely to see you again. Thank you for joining us.
Not working. Yeah. So I thank AIS APO for inviting me and making me part of this great glaucoma program. And my topic is on mixed and angle closure glaucoma with and without cataract. So VIX is increasingly used for all open angle glaucomas, and its role in angle closure glaucoma is still less established. But now there is an increasing evidence that shows that some mixed procedures can be used in combination with or without cataract surgery in angle closure glaucomas also. So when we look at the outflow pathways, you have the conventional pathway where the aqueous exits to the eye, to the trabecular meshwork and Schlem's canal and the aqueous veins. And there are some mixed procedures which are targeting this conventional pathway. They are the stents and the goniotomies. When we look at the US choroidal pathway, we had a good discussion. The aqueous exits to the supraspinatus into the choroidal vessels, and CyPass is one of the mixed device, and now we heard about the mini-eject also. So in angle closure disease, what is the main mechanism? Basically, there's dysfunction of the trabecular meshwork and Schlem's canal. The conventional outflow can be blocked physically by iris or secondary damage by inflammation ischemia to the trabecular meshwork. So removing this physical obstruction and enhancing the trabecular meshwork outflow may be the best option before considering or creating a non-conventional outflow pathway. So the mechanical blockage is often relieved by surgical or the laser iridotomy, a laser iridoplasty, the goniocyclolysis or cataract extraction. And the dysfunction can be addressed by targeting the TM canal junction, including the incision, trabectome, catheterization or microstents. So what are the surgical options when you have angle closure disease? When you have a cataract, you can do a cataract surgery with or without a trab, or with or without a goniosynovitis, or in combination with any mixed procedure, or with or without goniosynovitis. And when you don't have a cataract, as already Dr. Zivrin has said, the surgical peripheral iridotomy along with GSL, along with goniotomy works best. So TM surgical options is you can either remove, cut or dilate the trabecular meshwork or the Schlem's canal, and we have a lot of options to choose from. And for the trabecular bypass, you have the high-res or the eye stent. So what we look at ab internal goniotomy, basically characterized by incising or removing the trabecular meshwork and the inner wall of the Schlem's canal, typically covering 120, 240 or 360 degrees circumferentially. And now we have a data which is already published that when we compare the different degrees of cutting the trabecular meshwork, 120 degree is giving the same result as compared to 240 and 360. So when we look at the evidence, cataract surgery with or without goniosynovitis were more effective in IOP control in the early to moderate stage of angle closure glaucoma than in advanced disease. So the RCTs have shown that cataract surgery in combination with GSL and goniotomy is more effective in advanced disease. So now we have an option for treating both the early disease as well as the advanced disease. It's just that we just have to combine a mixed procedure in advanced disease. So when we look at the literature, China et al. Studied the evidence of efficacy and safety and role of mix and concluded that combining cataract surgery with mix in eyes with PACG can achieve greater IOP control and glaucoma medication reduction than cataract surgery alone. So when we look at the different types of mixed procedure which has been studied, which has been evaluated and published for angle closure disease, there are a lot of studies and you can see the procedures also in the surgery type which is done. Most of the studies were combined with cataract, GSL and goniotomy, and in the goniotomy also it was more of the limited goniotomy than the C60 circumferential gap or the compared to the stents, that is iStent stent or the ciliary ablation or the micropulse. So when we look at the phacoemulsification with GSL with goniotomy in angle closure glaucoma, there's enough evidence which suggests that there's a significant and long-term reduction in IOP and anti-glaucoma medication, along with improvement in the best corrected visual acuity, especially following cataract surgery. And this goniotomy was done with KDB or MVR or a bang needle. So it's a small video. I'm just showing it. This was a case of angle closure glaucoma. This is the LAN spatula, the GSL spatula. Can we reduce the volume, please? So I'm just trying to separate the sinus case with this GSL spatula. And you can see, as I'm trying to separate the iris tissue from the trabecular meshwork, the trabecular meshwork is visible now. And then with this LAN micro hook, it is a hook device by Zulinzan. And this is LAN micro hook. I'm doing a limited goniotomy of 120 degree. So this is the best option available in angle closure glaucoma. In one go, you can do the goniotomy, and this combined with GSL works best. So when we look at this combined procedure with the GAT goniotomy, there was a reduction in IOP and number of IOP medications also. When it was compared with trabectome, that also showed it to be effective. When we look at the impact of the extent of PAS on mix, this was studied by Len Fengbin et al. And they concluded that it is the phacoemulsification with GSL goniotomy has proven to be an effective treatment for PACG with cataract over 1 year period, and the outcome was not correlated with the preoperative extent of PAS. So whatever degree of PAS you have, just do 120 degree goniotomy along with the cataract surgery and you have good results. So this procedure mix was also studied. I mean, this cataract surgery and angle closure was studied, the iStent also, and there was a good significant reduction in IOP and medications. There were other studies which were done, but because the sample size is small and the benefits still remain unclear. So coming to phacogoniotomy, the bang procedure, and especially in our country, in India, this is the most commonly performed mixed procedure because of the economic issues. So a 25 gauge needle is taken, and after doing the cataract surgery, a limited 120 degree goniotomy is done, and we get a nice cleft in this. So when we compare the phacogoniotomy versus phacotrabeculectomy, Song et al. Has investigated the effectiveness and safety of this procedure in advanced cataract with PACG, and he has proved that phacogoniotomy is non-inferior to phacotrab, and phacogoniotomy provided additional shorter surgical time, lower postoperative complications, fewer postoperative interventions, and better postoperative quality of life. When we look at the systemic review and meta-analysis, which was done by Fake et al., they said that there was a mean reduction of IOP by 7.7 and in medication by 1.57. And he concluded that sustained reduction in IOP and medication burden with favorable side effect profile was seen in angle closure eyes when mix was done. Mixed phaco may be superior to standalone phacoemulsification, and mix should thoroughly be considered for mild to moderate angle closure glaucoma with coexisting cataract before going to the more invasive glaucoma surgical approach. This is a small surgical video by Dr. Tulin Zhang. She has said me to, I don't do this procedure, but it is already published, and she's been doing good amount of surgeries. And I think there's a case series of 328 cases already she has published. You can see the surgical iridectomy is done, and once this is with cataract, basically phacogoniosynical lysis with surgical peripheral iridectomy with goniotomy. So she's injected the high density visco as we all do for the mixed procedure. And after the surgical peripheral iridectomy, now the visco is placed over the cornea and the gonio lens is applied. And after doing the GSL, the goniotomy is done. So always try to visualize how many quarters you are going to do the GSL, where are the pass. You can see nicely, this is the same spatula which I showed in the previous video, which is invented by her. So in advanced PCG without cataract, surgical peripheral iridectomy, goniosynical lysis with goniotomy, the 9 months outcome is published, and it is found to be a new treatment options. We also have the 1 year outcome by Gao et al. And he also shows that this combined procedure of SPI, GSL, and GT is safe and effective surgical approach and has a great potential as the first line treatment options. Again, now earlier the data was less, but now we have a 2 year data also. which says that this procedure gives a good surgical approach and it should be considered as a viable alternative to TRAB. As already mentioned by Dr. Zulin, she has shared me this slide. She compared the 2-year outcomes, and phacogoniotomy is supposed to be non-inferior to phaco-TRAB. So earlier we used to always feel that in angle closure, PI, and then a phaco-TRAB is a surgery of choice. But now we do have an option of phacogoniotomy, and when 1-year outcome is there for the glaucoma patients with cataract, you can do an SPI with GSL goniotomy, and it is found to be non-inferior to TRAB. So to conclude, there is an available evidence and experience which suggests that mixed in angle closure disease with cataract, you can do a phacoemulsification plus or minus gonius necrolysis plus goniotomy, or without cataract, you can go with a surgical peripheral iridotomy, gonius necrolysis, and goniotomy, which can be safely and effectively performed and can achieve greater IVA and glaucoma medication reduction. Thank you.
I mean, thank you very much. There's a huge amount of data. What do you do?
So
What is your actual practice?
As I mentioned, when it comes to angle closure glaucoma with cataract, I always combine the phaco-cataract surgery. If there is a pre-existing pass, sometimes it's a diffuse pass or there is a limited pass, I do the gonius necrolysis and I use the bank. If the patient is affording, I use a KDB. But most of my goniotomies are done with the land microhook because I found it more stable. And so with the 25 gauge bank, the cleft is very narrow. It's a very small slit. And with the KDB, it's very wide. But with the land microhook, it's a perfect slit what we get.
And you're getting good results of that?
Yeah.
Yeah, beautiful. Should we move on? Yeah. We should move on. Thank you so much, Amit. Keith, our next speaker is Keith. If he's just finished his talk, he's just in the process of doing it now. No, that's not true. It's tomorrow's, isn't it, Keith? There we are. Keith needs, that's right. That's right. Keith needs no introduction, and I therefore will not give one. It is lovely to see you again, Keith.
Thanks, thanks, Mike, for inviting me to give a few sound bites about MIBS versus trabeculectomy. I've got a number of my main disclosure is really the interest in the pole glaucoma implant. Although I've worked with pretty much all of the minimally invasive bleb companies. You know, in the past we had one surgical option with trabeculectomy, which has now been there around for 67 years. And it's nothing at all like the trabeculectomy which we do today, which has really evolved quite a lot. But there were some similarities in that it involved a sclerostomy, but whereas the flap was completely different. And trabeculectomy has slowly evolved, but it's still an unpredictable procedure that requires a lot of experience and volume to be confident in what you're doing because of the amount of post-operative care that's required. But despite all that, it still is the most effective procedure overall for treating glaucoma. But as I've mentioned, it's unpredictable, requires intensive follow-up, and success is highly dependent on case selection, and I'm telling you everything that you already know. What about minimally invasive bleb surgery? You know, it's doing the same thing, exactly the same thing as trabeculectomy, with easier surgical technique, less intensive post-operative follow-up. So this should, in theory, be ideal. You've got the Zen implant and the PreserFlow, and as I mentioned briefly tomorrow, there's a whole lot of other subconjunctival devices. Now that the canal space is completely overcrowded with about a dozen different techniques that do exactly the same thing in slightly different ways, I think the enthusiasm is slowly spreading into the conjunctival space, and we'll see a lot more devices in that area as well coming through. We've got one major randomized clinical trial, which Yinghan has already shown briefly this morning, the PreserFlow FDA study. And it was a randomized clinical trial versus TRAB. And 2 years, TRAB was doing a bit better. Surprisingly, the PreserFlow didn't get FDA approval, even though it's producing a 30% pressure drop. It's not getting pressures as low as TRAB's, but it's still getting them a hell of a lot lower than an iStent, which got approved. And it has puzzled me as to why the minimally invasive bleb procedures don't get pressures quite as good as TRAB's, even though they're doing the same thing. And if you look at the PreserFlow data, the survival curve, or rather the failure curve, the difference between TRAB's and PreserFlow seems to occur in the first few months. There isn't doesn't look like there's a long-term differential failure rate, which is interesting. They kind of fail very slowly at the same rate in the longer term, but the difference seems to occur really just in the first few months. And I just wonder why that is. Interestingly, you know, with canal procedures, people often talk about the main benefit being medication reduction. But if you want medication reduction, clearly a trab or a pressure flow reduces medication big time, much more so than you'll get from a canal procedure. We run this, Nathan Kerr in Melbourne, I run this glaucoma surgery registry, which is I'll give it a quick plug. We've got 5 surgeons in 4 countries that have entered more than 500 cases, and 28 surgeons in 12 countries that have entered more than 40 each. And we kind of glue them together and take the canal procedures, pressure flows and trabs. You can see that the pressure differential from in the canal stents or canal procedures, that 90% of which are combined with phaco, they're dropping okay to 13 from a starting pressure of 17, which is reasonable, I guess. It's not dramatic. Pressure flow is coming down to the same level from 23. Actually fairly effective. And trabs, interestingly, had a lower starting pressure around 21, but again, they're getting lower finishing pressures below 10. And notably, the pressure flow is only 10% combined with phaco, and the trabs only 5% combined with phaco. And it is interesting that pressure flows did have a higher starting pressure, and I think that probably reflects selection, that if we really want low pressures, we're more likely to go for trabs. But what about, as I say, canal procedures often touted to give you good medication reduction? Well, they don't really. You're getting from 1.8 down to 1. Pressure flows, you're getting from 3 down to less than 1. And trabs, pretty much wiping out medication usage completely. So when people tell you, oh yeah, canal procedures get the medications down, yeah, they do a bit. But it's not exactly something to write home about. So we get this sort of patient, what are we going to do? This is really why trabeculectomy still survives. It's that sort of patient who really needs to get low pressures. And don't let people tell you that that glaucoma just gets worse anyway, or that you do a little bit and then you do something else and you do something else. If you get these sorts of patients down to 7 or 8 or 9, they will not get worse. And don't let people tell you otherwise. When they're 95 years old, they'll still get worse. But short of that, if you can get them into single figures, they will not get worse. So there is an argument for getting lower pressures. This was an 80-year-old who came to see me with pressure of 17 in her right eye after viscocanalostomy, and the surgeon wanted to repeat the viscocanalostomy. I mean, apart from the fact that the definition of stupidity is doing the same thing over again, expecting a different result, a viscocanalostomy in the first place isn't even indicated in this patient because it's not going to get the pressure low enough. So not only is the first viscocanalostomy not the right thing to do, the second one is obviously not the right thing to do. And the patient eventually had a Paul tube and she's got pressure of 10. The patient was smart enough to have other ideas. So don't do surgery that won't achieve the necessary goal just because it's the only thing you know how to do. You know, if you don't know how to do proper surgery, find somebody who does and refer the patient to them, please. What do we need in glaucoma surgery? We need efficacy and IOP reduction. It's good to be safe, but it's no point being safe if you're not reducing the pressure. You know, you might as well do nothing. That's not any more dangerous. Here's a patient, a young myope, well, 48 years old, young in my opinion, who father had glaucoma as well, slightly thin cornea, pressure of 11. 2 months from presentation, pressure's 15 and feels marginally worse. And this is kind of what happened if you just watch over several years of follow-up. Despite pressures that were not that bad, and despite quite a few operations, and you see that feels just getting slowly worse. And eventually we stabilized her. I mean, she's now been stable for about 8 years, but the pressure had to get down to 8 or 9. And this is the point about trabeculectomy. This patient actually ended up having Barveld implants to get down to 7 or 8. But the point is, if you get a low target pressure, you can stop somebody like this from getting worse. And don't let people tell you otherwise. So the future of glaucoma surgery is still external filtration. Everything else is kicking the can down the road. But how do you leverage the efficacy of minimally invasive surgery that in theory should be equal to TRAB, but doesn't seem to be in the trials so far? Anyway, tomorrow you can hear how you might be able to leverage it. And I've run out of time. Thank you very much for your attention.
Thanks. Thank you, Keith. So, 2 questions for you. One is that as per the current publication, it doesn't seem that the Zen or the pressure flow are better than trabeculectomy.
They're not better, no. If you're in a practice where you don't do any trabeculectomy, and I've no experience with trabeculectomy, it's better to do a pressure flow than to do nothing, for sure. You know, pressure flow's low risk, other than the glaucoma getting worse if you don't get the pressure down low enough. They're not hard to do, and they don't require much follow-up. I've largely stopped doing Zens because the pressure flow is available. The disadvantage of the Zen was the limbal blebs, dysesthesia, blebitis, higher risk of infection. If pressure flow didn't exist, I still do blebs, but I do them ab externo, because I think the ab externo, I mean, when the Zen appeared, it was so attractive, this ab interno approach, but the blebs are not as nice. And I think ab externo with mitomycin far back gives you better blebs, and probably the Zen would be equal to pressure flow if you did them that way, and I think that's what quite a few people in the US now do.
And there's a new surgery where you don't put in any implant, you just do minimally invasive sclerotomy. So
yeah, I did 4 of them and none of them worked.
Okay.
I mean, when I say none of them worked, they didn't reduce the pressure even on day 1. I mean, I looked at them and thought, well, these are, you got to try something. And I thought they'd work for a while, but they didn't work at all. We just didn't get a single pressure drop.
Okay. Thank you, Keith.
Thanks, Keith.
We move on to the next presentation, Tube Techniques and SE Operation by Dr. George, who heads the glaucoma service at Arvind Madurai and one of the inventors of the Adi implant.
Thank you. Good morning, everybody. Can I have the slides?
AV team, can you put up the slides for Dr. George? Thank you.
Yeah, thank you. So thank you. So I have no financial interests to disclose. So why do tubes have a bad reputation? So I thought these are some of the issues which surgeons are worried about the tubes. Hypotony, which can be early, or it can be at the time of ligatures which are autolysis in non-valved implants. Tube exposures, corneal complications are something which are very dreadful. And also bleb encapsulation in valved implants and chronic persistent late hypotony in non-valved implants. It's not moving. So early hypotony, it's important to avoid peritubular leakage in both valved and non-valved implants. Your tubes should be snug fit in whatever tracks you make. Again, in non-valved implants, it is vital to have complete watertight occlusion. We do it with 6-0 polyglactin suture. This is critical. Some of you might be surprised if I tell you that early postoperative hypotony is more common in a valved implant than in a non-valved implant. In a non-valved implant, once you have avoided peritubular leakage and once you have completely occluded the tube, it's highly unlikely to get an early hypotony. But on a rare occasion, we have seen the valve malfunction in the Ahmed glaucoma valve causing early hypotony. So you need to rule out peritubular leakage. You need to rule out other issues like choroidal effusions or choroidal detachment or suprachoroidal hemorrhage. And invariably, you wait for about 72 hours, the AC doesn't form, you have to go back into the theater and completely occlude the tube with your 6-0 Weichel suture. Earlier, when we started this journey with the Orolab aqueous drainage implant, we did not use this intraluminal stenting intraoperatively. So once we have this 3-0 multi-filament nylon from Orolab, which is a Supralon, or the 4-0 polypropylene that comes with the Ahmed ClearPath, the problem, this is something which we're very worried about. The suture autolysis occurs around 5 to 6 weeks post-operatively, and there's a sudden decompression, and sometimes in high-risk patients like an aphakic with a vitrectomized eye, you could even end up with a suprachoroidal hemorrhage. Tube exposures usually occur 4 millimeter from the limbus. So something which you can do immediately is to bury the tube in the patient's own sclera for the 4 millimeters from the limbus. But the caveat here is to have a scleral tract of adequate depth and adequate length so that the tube snugly fits in the patient's own sclera. What we prefer is a 23 gauge needle generated 4 millimeter long scleral tract. If you see carefully, the more anterior you enter the anterior chamber with the tube, the risk of exposure is more. We corroborated it with our, especially in the pediatric eyes, tube exposures and extrusions were a very big issue. Once we shifted over to this 4 millimeter scleral tract, we found that the incidence of tube exposures in the very young has also come down. It's more of tube retractions, tube corneal touch, tube lenticular touch, and these are the issues faced in the pediatric age group. Tube retractions in the pediatric age group, we tend to err on a slightly longer tube in the AC, probably about 2.5 to 3 millimeter in the AC, as close to the iris as possible, compared to about 1.52 millimeters in the adult eyes. So this actually was a tube exposure. So the important aspect here is to reposition the tube to a different site in the anterior chamber once you have an exposure. If you just try to bring conjunctiva back, provide fresh donor patch graft and bring conjunctiva back, the same mechanical forces that cause the tube to expose in the first place is definitely going to cause the tube exposure to recur. So it's always important to reposition the tube to a different site and bury that in the patient's own sclera. Again, maximizing the distance of the tube from the corneal endothelium also enhances the success of long-term corneal survival. If you put a slit on the cornea, a slit on the tube, and there's a slit that falls on the iris, you need to maximize the distance from the corneal slit to the tube slit, and this has to be followed right from the entry into the anterior chamber. Whatever site you place it, this is an infranasal tube, where again you can see the slit is, you just see this tube is the slit on the cornea and the slit on the tube, there's absolutely no space, but there's a lot of space between the slit on the cornea, slit on the tube and the iris. Now, in fact, if we see the tube touching the iris, that is the most comfortable position, and you can rest assured that this cornea is going to survive for long term. We just see a small atrophic patch on the iris. You don't see any inflammation. You don't see any bleeding. I think this is probably the maximum chance of long-term survival. We did so the problem with this long scleral tract is once you do a long scleral tract, it's difficult to get the tube snug on the iris. Unlike when you enter nearer the limbus. What we found out that we did some accurate measurements, and as you can see, it is that 2.83 millimeter. I have a small animation to demonstrate this. So there is a 4 millimeter scleral tract, and there is a position where your needle has to change from parallel to the sclera to parallel to the iris. So this happens usually between the 2.8 to 3 millimeter, and that is where the groove of the needle ends. So there's a mental calculation involved. Probably if it's a deep anterior chamber, you might have to dip at 2.8 once the 2.8 millimeter of the needle goes in. If it's shallow with a phakic eye, probably you will have to go 3 millimeter and then dip. Tube positioning is critical. This was the first picture. Probably everything looks fine, but if I put a slit, I see the space between the cornea and the tube is very less. Invariably, you need to catch this early and you need to reposition these tubes into the anterior chamber. There are two aspects here. If the tube enters the cornea very close to the tube enters the anterior chamber very close to the cornea at its entry, you have to reposition the tube. And in certain occasions, we see that the tube enters the anterior chamber close to the iris, and then there is a anterior movement. The tube touches the cornea. This is a much simpler procedure, and this is mostly seen in pediatric, where you can easily go in and trim the tube. How to avoid long and short tubes in the anterior chamber? We have done some markings, and the initial scleral groove, whether it's the right eye or the left eye, is done 2 millimeter medial to the original position of the tube. And then the tube is trimmed at 2 millimeter at the original position of the tube. If you then root this 2 millimeter, the 4 millimeters track is made medial, you end up with an ideal 2 millimeter length of the tube in the AC. We have also found that this sinuous track is surgical insurance against any repositioning procedures we have to do later, whether it's for tube exposures, tube corneal touch, or for tube retractions. We have adequate length of the tube still in the AC to reposition these tubes. This technique initially we thought it was something to do with a scleral patch, but we later on came to realize that burying the tube in the patient's own sclera in a 4 millimeter scleral track, and this technique has been beautifully described in this paper. We may have to reposition tubes into the anterior chamber at areas where there is more adequate depth. Again, the question is, how do we measure the length of the tube? So what we found that if you have to position it 4 millimeter away from the original track, you need to trim the tube 4 millimeter anterior to the cornea in the original position of the tube. Just two things here. Surgeons, we have randomized control trials, the ABC and the AVB. We were worried about bleb fibrosis and implant failure due to high IOP in both the ABCs and in the valved implants. And surgeons are worried about chronic hypotony in non-valved implants. I just want to put in a word here that the supralon suture can be guided into the tube, and this seems to be a highly effective weapon in the armamentarium to reverse late post-op hypotony, which we are worried about in non-valved implants. This cannot be done with monofilament. So I just want to conclude that meticulous attention to surgical details is extremely important. You need to stick, just a simple thing like you need to stick to a particular quadrant. You need to ensure that the episcleral plate is 9 to 10 millimeter posterior to the limbus. And extremely important is the post-operative lifelong care to ensure we preserve useful vision in refractory glaucoma with tubes. Thank you very much.
Thank you, George. That's excellent, and lots of tips there. Do you ever put the tube behind the iris? Do you ever put it in the...
Yeah, so there are certain situations where we put the tube into the ciliary sulcus, like there's an anterior pass in uveitic glaucoma, or sometimes in an Axenfeld rigor or an iridocorneal endothelial syndrome. We put into the sulcus. And again, it's a minor adjustment about those calculations. I said you dip it 2.8 to 3. Sometimes you might dip it about 2.6 millimeters. And sometimes there's absolutely no option. And as Dr. Ying was mentioning, there is absolutely no space. Even in the sulcus, you might have to do a pars plana vitrectomy and put it into the pars plana, but it has to be a complete vitrectomy, and with adequate shaving of the vitreous base. Even a little bit of vitreous there will come and block the tube and predispose the tubes to fail. Another option where you can put in a pars plana tube is when you have a vitrectomized eye, you have a bad cornea, you can try risking it in the pars plana. But the problem is, just in case the patient needs a vitreoretinal procedure later on, it becomes difficult.
You can always hear someone who's done a lot of these. Thank you. Sorry, yes.
Can you give them
Got a microphone?
Thanks so much, Dr. George. That's excellent talk. I'm advocate for sulcus tube, but I feel one condition actually I want to be a little bit more careful. It's a uveitis patient. The reason for that is for all the patients we did, like primary, secondary, MVG, so on and so forth. Uveitis patients sometimes a little bit hard to predict. And even intraoperatively, the sulcus tube looks really good. Postoperatively, sometimes the iris can sneaky with the anterior capsule, and then you end up tenting on the tube, like iris, and then causing pigment disperse, like not like a white cell, but it's pigment in the AC. So I have multiple patients, one eye AC tube, one eye sulcus tube for uveitis patient. AC tube in that case actually quieter in those few patients. So just want to add this to.
Thank you.
Talk.
Thank you.
Thank you. Yeah. And Shan Lin's going to finish up. Shan is professor and director of the glaucoma service, in the University of California in San Francisco. He's going to talk about a really completely irrelevant topic, which is how to make glaucoma patients see better, which is not very important at all. But thank you very much.
So Michael's right. I want to thank Tanuj and Michael for inviting me to be giving a talk. But yes, I'm changing gears on you. All these talks about the glaucoma aspect, the glaucoma surgery, but I'm going to actually focus on the cataract surgery. And as Michael mentioned, how can we optimize the visual outcome for our glaucoma patients when we do cataract surgery? My financial interests are not related to this talk. And here's an outline, and I'll apologize in advance if I go over a little bit, a couple minutes, but I think we do have some time, so I think it'll be beneficial to hopefully all of you and your patients. We're going to talk about toric IOLs, multifocal IOLs, including extended depth IOLs, intraoperative aberrometry, intraoperative image guidance systems, so a lot of technology here. And ultimately, things like the choice of your IOL for your angle closure patients. We talked a lot about angle closure. Is monovision a good choice for your glaucoma patients? And lastly, laser adjustable lenses, those very sexy high-tech lenses that are available, also very expensive lenses. So let's start with toric IOLs. Is this right for your glaucoma patients? And these are some examples, and there's more of them from our different companies that make intraocular lenses. And this is a little bit of a summary of what you would take home for our glaucoma patients. Giving the different types that you can do, the LRIs and toric IOLs. So for the toric IOL, you have a little bit of advantage of a greater range in terms of correction of the the astigmatism. You have no loss of contrast sensitivity with both types of procedures, and you probably have a better accuracy in long-term stability with toric IOL. So that's my go-to of choice. I've done LRIs before, and maybe it'll correct a little bit of the astigmatism, but you can't count on much of it. So here again is the summary that I was telling you about, choice of toric IOLs for your glaucoma patients. And if they have no visual field loss, or they're just suspects or ocular hypertensives, I think the answer is easy. Yes, you can do a toric IOL. These are like your regular glaucoma patients, assuming you don't expect very severe or very rapid progression of glaucoma. If they have peripheral visual field loss, I would lean towards, yes, it's okay to do a toric IOL in those patients unless you think they're going to advance very quickly. Those patients with central field loss, there may not be such a benefit for the patients. There's probably not going to be any harm to put a toric IOL, but we'll talk about the financial cost of the patient. And lastly, for patients with pseudoexfoliation and trauma, which we don't see very much here in Asia in terms of pseudoexfoliation, those you probably don't want to put a toric IOL unless you're absolutely sure that the bag is stable. As I said, for us in glaucoma, the severity of glaucoma is very important. And so if you have somebody who has very severe glaucoma and they have very poor central vision, is it really beneficial for the patient when there's a cost? And when I say cost, a financial cost, as all of you know. This is everybody, at least in America, has to pay extra money out of their own pocket to purchase the toric IOL. And you have the same issues with macular degeneration, for example. You want to look at the stability of your glaucoma as well. Are they a rapid progressor? Well, then that's going to change your mind in terms of that patient as opposed to a stable glaucoma. If you have a person who's had trabeculectomy, do you do a toric IOL? Well, what happens with trabeculectomy is usually you have this with-the-roll astigmatism, this vertical astigmatism, and in most cases, that at least in my experience, it's been not only with the roll, but also tends to be not irregular astigmatism. So I think a toric IOL can be beneficial in these patients. You want to usually have it, 6 months away from your trabeculectomy. And the answer about whether you do a toric IOL, again, goes back to that critical idea of whether their foveal sensitivity or their best corrected visual acuity is really to the patient's advantage. If they have 20/80 vision, 20/100 vision that you expect, maybe that little correcting one astigmatism, a diopter of astigmatism, isn't really going to help them all that much. And the macular OCT may be able to help you as well. How about combining, we were talking about all these combined surgeries with cataract surgery, especially for closed-angle glaucoma. Well, I would say for MIGS, you can do a toric IOL. And again, most of these are going to be mild to moderate glaucoma patients, so you probably can do a toric IOL in the majority of those patients. If you're doing a trabeculectomy or a tube, and that we've discussed here, most of those patients are pretty severe glaucoma. That's one factor, but another factor is when you put that tube in or you do a trabeculectomy, you're inducing astigmatism often, or you're changing their axis of astigmatism. So I think we have to be a little more careful in those cases. Limbal relaxing excision, as I said, because of its mild effect, I really have shifted away from doing LRIs. How about multifocal IOLs for our patients? So these are quite expensive in the US, I'm sure elsewhere as well. But these give the patient the possible freedom from glasses. Right here are some examples of these. And I've put many of these in, but again, these are patients with very mild or almost no glaucoma. Same sort of algorithm here. If they have almost no glaucoma, they're just a suspect or ocular hypertensive, yeah, I think it's fair to put a multifocal IOL. Peripheral visual field loss, I'm a little bit against it as opposed to the toric. I feel that there's obviously, they've already lost some contrast sensitivity probably, and they have possibility of progression. So you may actually do them harm by putting in a multifocal IOL, taking away some good vision such as their contrast sensitivity. If they have central visual field loss, I would say it's pretty much a no. And if you have pseudoexfoliation and trauma because of the shift, how important it is to be central, I think will be also a no's in this case as well. Again, critical factor is contrast sensitivity, which comes out in measures, especially at night, for example, when you have to see different shades of blue are going to be affected in terms of glaucoma, and multifocal IOLs, even the EDOFs, make it worse. But overall, the visual outcomes, and this matches for my patients, you can achieve about 20/20 vision for far, intermediate, and near. So they do well overall, and they're some of my happiest patients, because now you've taken somebody who's very nearsighted, for example, and they don't have to wear glasses at all. Centration is critical. All of you know that. If you're a little bit off by just being a little bit like half a millimeter off from the center, boy, you've lost some of the central effect, near effect of the IOL. So this is critical to spend that time and be very careful during your irrigation and aspiration. Extended depth IOLs, extended depth of focus IOLs, give you that sort of benefit in terms of giving you some intermediate. It doesn't quite give you all of the ranges of IOL of visual focus, but you get the little bit of benefit, and maybe you can see your iPhone without your glasses. They seem to have less contrast sensitivity loss than multifocal IOLs for our glaucoma patients, but the near vision isn't as good. And I would still tell you to be careful. I give the same criteria for EDOFs as I do for my multifocals, and I tend to lean away from them if they have pretty significant glaucoma. Intraoperative aberrometry, this is some technology here, I think relatively expensive, and there's added cost for the patient because you have to pay every time you use this technology. We use the Aura from Alcon, but it's been invaluable for me to make sure that lens choice is the correct choice. Because as all of you know, and all of us have experienced who are cataract surgeons, wow, you get that myopic surprise. It's 2 diopters off of what you expected, and this will help you in achieving that correct refraction. I use it not in routine cataract surgery, but I think our post-refractive surgery patients, my LASIK patients, my patients who I'm going to do toric IOLs, that's been very helpful for me in terms of, making sure that that's the right lens to put in. And I'm not going to show the video here, but it takes just a few minutes. Those of you who can, who've done it multiple times, realize it just takes a few minutes to make sure that, everything's centered, and then it chooses the correct intraocular lens for you. Image-guided systems, also I've incorporated that. Again, all of this seems like so much technology, so much extra expense and everything. But again, if you want to get the best outcome for your patients, this is what I do for my toric patients to make sure I'm in the right axis. It's even better than you marking them in the pre-op area and making sure it lines up with where you think it is, because that's rather crude in this day and age when we have technologies to tell you exactly where to put the intraocular lens, and even afterwards make sure that it lines up correctly with what is supposed to be the axis. How about your choice of clear lens extraction in angle closure glaucoma? We've talked a little bit about that. when you choose your IOL, again, you have to be a little careful. These are people who are often hyperopic, and you can often have a very myopic shift. I think almost everybody in here has had somebody who's a +3, and you end up with what you thought was plain, you wanted to be plano, but you were a -2. I certainly have had those cases. It's been published before. It's because the lens iris diaphragm is more anterior in these patients, so an aura would help in those cases. Multifocal may be an option in these patients, but you have to be a little careful because, again, poor predictability. We're going to talk about monovision. Maybe mini monovision is better, where the difference between the two eyes is rather subtle, rather small, so that in glaucoma, if you have one eye distance, one eye near, the worst eye maybe is going to lose its vision in the future. So that's exactly the point here. If you have the traditional monovision of 2.5 diopters difference, that's probably a little bit too much for our glaucoma patients who may be almost blind in one eye or may go blind in one of their eyes. So I think mini monovision may be a good choice where there's a little difference between the two, but not so much that your brain can't sort of put it together. And I'll lastly talk about LALs. Very expensive in the US. The upcharge is $5,000 to $10,000 per eye, but these graphs are showing that you don't have the loss of contrast sensitivity as you do with multifocal IOLs. It really is a monofocal lens, but you can adjust it afterwards, so you get, in some ways, whatever range of multifocality is going to be a little bit better because you can adjust the lens power afterwards. So in summary, premium IOLs, don't say no to that for your glaucoma patients. You can help your patients a lot. If they don't have visual field loss, the answer is easy. Yes, you can do it. If they have some peripheral visual field loss, maybe. And if they have central visual field loss, maybe the answer is no. No with pseudoexfoliation and trauma. And again, all these technologies we talked about to help our refractive outcome in our patients. Thank you.
Thank you, Shan. So your decisions are based on the visual field. But many times you have cataract and glaucoma where the visual fields are not reliable or may not be possible. So then how do you decide on the type of IOL for those patients with dense cataract?
Yeah, Tanuj, you're absolutely right. I think that's where our clinical assessment comes in, right? We look at the optic nerve, and if that looks like a 0.99 optic nerve, there's no benefit really for the patient to get this multifocal toric IOL necessarily, or laser adjustable lens, when in fact their visual acuity is only going to get to 20/80 at best. So that comes into it. Again, the OCT will help us as well. And you know, you have to just use your clinical acumen and look at the history of the patient to see, what is the potential vision of this patient? You know, is this going to be beneficial to the patient? Yeah, good question.
Thank you.
Do you take into account, Shan, where they've got to in their cataract journey? I mean, you know, some people are complaining at 6 on 7.5, and some people walk in and you're only doing it at 6:30. Do you have a sense of if someone has let their cataract go for a length of time, does that make it less likely for you to use a premium lens?
Yeah, again, each clinical situation is different, and you know, you also have to look at the patient's needs, their ability to pay. Number one, you know, if it's something that doesn't make sense, that's a huge difference. That's probably the number one factor as to whether they're going to get a toric or multifocal. But you're right, I'm putting all those factors on the table because you're talking about this case of a patient where, you know, that is a 3-4+ nuclear sclerotic cataract or a very dense PSC cataract, and is there a benefit to them? And ultimately, I think it comes down to talking to the patient and also setting low expectations. So I think one of what speakers today said, it's very important to make sure that the patient, you know, expectations are everything. You know, if they think they're going to get 20/20 vision like their friend who only had a cataract, that's going to be a mistake, especially if you have any significant level of visual field loss. So I think, Michael, your point is right. Setting those expectations, and then it comes down to the individual. You know, does it make sense to put a toric IOL in? Multifocal, probably not if you're not sure what their level of glaucoma is because it's a dense cataract and how much they're going to get better. But the toric IOL, I think, is where it can really benefit the patient in terms of just being able to get up in the morning and seeing better, no glasses. I often tell my patients, if it was me, you know, I know there's extra cost, but the toric IOL, and I have plenty of astigmatism and nearsightedness, as you can see, I would pay the, you know, I mean, there's really no harm in that, and all the technology is great too if you have access to it.
No, I certainly agree with that.
Yeah.
Thank you, Shan. So we have a couple of minutes, and I want to ask a few questions to our panel. And maybe Keith, could you please help us? So in India, we have access to all these devices, but majority of the population cannot afford the devices. So the question is that majority of us do cutting MIGS. So is more better, like how much of TM is the ideal cutoff between efficacy and safety? Because a lot of surgeons are now doing GAT as a first line MIGS and its entire 360 degrees being operated. But literature shows that even you can get the same efficacy with 90 or 120 degree. So Keith, what would you suggest? How much of the TM should we be operating as a first line MIGS for developing countries?
I don't know. All the trabecular meshwork stuff's doing the same. Obviously, GAT is more dramatic, but then you're basically ripping over 360 degrees. And logically, the original iStent study showed that 2 gave you more efficacy than 1, and 3 was there's only marginal difference, and it really boils down to, I think, whether you're hitting the collector channels or not. I mean, you've got it's not a circumferential highway. It's discontinuous, and you've got to open it up enough to get to a certain point. And where is that point? It's probably not more than 90 degrees. I just can't imagine that 360 really is making much difference. Alex Wang, you're you're a canal guru here in anatomy and physiology and everything. How much canal do you need to open to actually get I mean, you can't get beyond a certain point. So what you're asking is how much do you need to rip to get there?
Yeah, I mean, I don't think the answer is known. I mean, your first answer, I don't know, is going to be my first answer. I don't know as well.
I thought you're almost certainly going to know.
But I think that what happens is that it's the underlying anatomy that actually dictates that. Because the underlying anatomy can be so variable, a 90 degree to 120 in one person in the right place may do it, because you're still trying to access what's going on distally. But if a person has a different anatomy, that same degree may not work. And really, I think the message is to be stereotyped and do the exact same thing in everyone may be a problem, right? The thing about 360 GAD is you're going to do something, but you're causing much more damage. And you're going to get a much more fibrotic response in return. And so then this is really about learning where to go, and then maybe then we can say, if you're in the right spot, 90's enough.
Yeah, I mean, GAT, Alex has actually encapsulated my concerns about GAT is it's not so much how much you open as how much scarring you create afterwards. It's kind of GAT's a quick fix, but what's the long? I mean, you're ripping the shreds out of the meshwork. What response are you creating?
Keith, do you ever use Vision Blue or something afterwards to get an idea of where the collector channels are? Alex, is that something you do? I mean, that seems to make sense. So we've got evidence that the canal of Schlemm is not a continuous device.
The canal of Schlemm is definitely variable in terms of its diameter going away all the way around. If you can consider the portions that are tiny, 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 it's essentially continuous, but it can get really, really, really small. And then clearly the collector channel distribution is non-uniform. I mean, right now what we're doing is combining this really weird study where you have angiographic imaging to see where the fluid flows, but the angiographic stuff only sees distal and not Schlemm's canal and collectors. And at least in the laboratory, if we put whole milk, so you go to the market and you buy milk, and you put milk in the eye, milk actually acts like blood for OCTA, so then you do OCTA with whole milk, and then you can see what's going on in flow in Schlemm's canal and collectors, and then you do the histology to have the gold truth. And what ends up happening is that some of the regions where you have no flow actually still has collectors there, right? With or without flow with the milk, but on histology you still see it. And so there's this really weird structure function thing that's got to be put together like a map, similar to how we do in glaucoma with OCT and visual field. And this becomes almost like a four-dimensional chess game to figure out what's going on. But once that's understood, then I think Tanuj Dada, so your idea about how big, then it could be applied.
So, as Tanuj sir has already published about the aqueous angiography, we all know that the collector channels are more on the nasal angle. And that's what Dr. Julian compared. So when we look at 120, 240 and 360, the 120 gives the result as par with 240 and 360. So why to damage more of the, cut more of the Schlemm's canal, and you can have the equivalent result in 120 degree. And second thing, you also have a publication of 30-degree goniotomy which you have published recently. So that also is giving good result, but there's no comparison, but with 30-degree goniotomy also, the IOP reduction was good. Only thing which I felt was, whenever I do the goniotomy, I do not an aqueous angiography, but I use strip and blue and inject it, and I see the dye escaping through the correct channels. So even though you have done a good goniotomy, some cases you can see the dye escaping to the correct channels, some cases they don't escape, but there is an IOP reduction. So we really don't know how much is the correct channels are working and the dye is escaping from where.
Yeah, I think that's a very important point, because without knowing the structure function of the TM, to remove the entire TM is not the right approach. So that is why I have been cautioning against 360-degree surgery without realizing, because initially it may work, but you don't know what is going to be the wound healing and the fibrotic effect, and it may be worse than the initial disease.
So the fibrosis will be more with GAT when we compare with limited goniotomy in the long run.
Yes, yes. So I think we have come to the end of the session. So I just thank all the speakers. And Michael, it was a very nice, interesting session. Lot of new things to learn. Thank you, everyone.
Thanks, everyone. Good on you.
Photograph. Photograph. Please come for a photograph.
Recording